All right. Hello, everyone. We're going to discuss the CBT questions of obs and gynae today, right? Let's look at the first question now. Question 1 says, all are causes of ambiguous genitalia, right? So that's the first keyword here. And the second important keyword here is in a XY child, right? So we are talking about ambiguous genitalia when the karyotype is XY, right? And that is the most important word here, and the answer is going to be 21 hydroxylase deficiency, right? So please remember, 21 hydroxylase deficiency causes ambiguous genitalia in a girl child or in a XX karyotype, not in a XY karyotype. It does not affect the development of the genitalia in an XY child. It is going to be in a XX child, right? Rest of the three, whether it is 5-alpha reductase deficiency, partial AIS, or 17-beta hydroxy dehydrogenase are causes of ambiguous genitalia in an XY child. I think option B and C are quite easy for you to understand. I might have to explain option D a little. So option B says 5-alpha reductase deficiency. We all know this is the enzyme required for conversion of testosterone to dihydrotestosterone, and then it is actually the dihydrotestosterone which is responsible for making up of the male type external genitalia, right? So when there is a deficiency of 5-alpha reductase, this conversion will not happen, right? So dihydrotestosterone is not formed, and as a result of which the external genitalia do not get virilized and they may remain ambiguous. All right, please remember, in 5-alpha reductase deficiency, the internal genitalia will be very much like that of a male, right? The internal genitalia that of going to be a male. The reason is because for the conversion of internal genitalia into male-like structures, there is no requirement of DHT. For this, there is only requirement of testosterone, and as a result of which the internal genitalia are very much going to be like the male. All right. Option C, let's look at this, partial AIS. So this we all know is a defect in the androgen receptor, right? And again, for the same reason, you know, the dihydrotestosterone, which is actually formed in the periphery itself, which is at the level of these external genitalia, the receptor is not sensitive to these male hormones and therefore does not get converted into male-like structures, right? Whereas the genotype is very much XY, there is development of a testes and there is also production of testosterone, right? But as I said, the receptor is not sensitive, so they do not convert into male-like structures. Now, when you talk about 17, option number D, which is 17-beta hydroxy dehydrogenase deficiency, now this is a deficiency which results into defects in testosterone synthesis. Okay, so it results in defects in the testosterone synthesis, and as a result of which these patients have very low serum testosterone levels. Right, so the serum testosterone levels in these patients are less, and as a result of which the external genitalia are only partially virilized, right? And as a result of which I said the external genitalia are only partially virilized, which again leads to ambiguous genitalia. All right, the other conditions which may cause ambiguous genitalia in an XY child, which you should remember, especially amongst the congenital adrenal hyperplasia ones, is 17-alpha hydroxylase deficiency as well as 3-beta hydroxysteroid dehydrogenase deficiency, right? Right, so these are the other two which may cause, ambiguous genitalia in a XY child, right? So this is what you need to know for this question, all right? Now, when we talk about, let's go on to question number 2. Now, this is a question which says a study was done in a group of girls with delayed puberty, right? So a common, or the first keyword here is delayed puberty, and the second keyword is they all have hypergonadotropic hypogonadism. So those are the two words here. Now, when we talk about hypergonadotropic hypergonadism, which means that the LH and FSH levels are going to be high, what does this tell us? This tells us that probably there is defect at the level of gonads, right? So the gonads seem to be defective. Why? Because if the gonads are defective, there is no feedback inhibition, and then the LH and FSH levels are high, right? Now, when you consider this and you think that the problem is going to be at the level of the gonads, what investigation should you do to find out, right? The answer is going to be karyotype, right? So the answer for this question is karyotype, right? And what is the most common cause? We all know the most common cause is gonadal dysgenesis, right? So this is the most common cause of primary amenorrhea, and as we say, they are going to have hypergonadotropic hypogonadism. And because gonadal dysgenesis is a group, we should know that the most common among the group is going to be Turner's syndrome, right? The most common among the group is going to be Turner's syndrome. And anyways, please remember that in cases of primary amenorrhea, whether it is with secondary sexual characters or without secondary sexual characters, the most important investigation to make a diagnosis or the investigation of choice is going to be a karyotype, right? It is going to be a karyotype, right? And as we all know that one of the one of the most important differential diagnosis when you talk about Turner's is Kallman syndrome. But what we should know is Kallman's, instead of it is not hypergonadotropic, right? So Kallman's is actually hypogonadotropic hypogonadism. Yes, so it is hypogonadotropic hypogonadism, right? And yes, pure gonadal dysgenesis is also a differential diagnosis with Turner's, but pure gonadal dysgenesis is very, very rare, right? So if you have to ever pick between Kallman's and pure gonadal dysgenesis, please remember Kallman's is going to be more common. Pure gonadal dysgenesis is a rare thing, right? And importantly, in Turner's syndrome, the patients are short-statured, yes? Whereas in both gonadal, Kallman's as well as in pure gonadal dysgenesis, the patients are going to have a normal stature, right? So they're going to have normal stature. So this is what I mean. So if we give you an open MCQ where we're just telling you that it is, normal stature, yes, and absent pubertal development, right? So there is normal stature and absent pubertal development, right? And you really don't know whether, we are not giving you any more details to tell you whether it is pure gonadal dysgenesis or Kallman's. That's what I'm saying, that then at that time you must go with Kallman's as a better answer than pure, because pure gonadal dysgenesis is quite rare, right? So these are the things that you should know when we talk about hypergonadotropic hypogonadism and its differential diagnosis. All right, and one of the other things that I would like to take up here is, we were talking about mixed. So there is a third type of gonadal dysgenesis as well, right, which is mixed gonadal dysgenesis. Now when you talk about mixed gonadal dysgenesis, I want you to know that in mixed gonadal dysgenesis, again, just like the previous question, here as well, the patients are going to have ambiguous genitalia, right? They will have ambiguous genitalia, and very importantly, they are going to have structures of both derived from Mullerian ducts as well as Wolffian ducts. And if you do a karyotype, they turn out to be mosaics, yes? Whereas when you talk about either Turner's or you talk about pure gonadal dysgenesis, they do not have ambiguous genitalia. They rather have very much female-like external genitalia, right? So they have female-like external genitalia, right? So those are the other things that you should know, right? And since we've been talking in the first question about ambiguous genitalia as well, and here also, one of the other important causes of ambiguous genitalia at birth is a true hermaphrodite, okay? And remember that true hermaphrodites, so they also have ambiguous genitalia. They are a differential diagnosis of mixed gonadal dysgenesis. So they're DDs of each other, true hermaphrodites and mixed gonadal dysgenesis. And in order to know which one is going to be which, we need to do a biopsy from the gonadal site. That's the only way to know it, right? So you do a biopsy from the gonadal site and you send the tissue for histopath. What will happen is, in true hermaphrodite, whatever biopsy specimen you send, the gonadal tissue will have tissues derived from both ovary and testes. So it's called as an ovotestes, right? So the elements of ovary as well as elements of testes would be present. Whereas in mixed gonadal dysgenesis, it is not like that. In mixed gonadal dysgenesis, on one side there is a streak gonad, right? And on the other side, it is a malfunctioning testes, but only elements of testicular tissue would be there. There will be no elements of ovarian tissue. Whereas when you take a biopsy in true hermaphrodite, as I said, it is a novo testes either on one side or on both the sides. And therefore, no matter what tissue you take, it will show you elements of both ovaries as well as testes, right? So these are important, and a lot of times, these questions are being asked in the exams more and more, and in all exams, not only in all India. The AIMS and PGI people are also very fond of asking questions related to ambiguous genitalia or gonadal dysgenesis, right? Let's move on to question number 3. So all the following are used for diagnosis of cervical incompetence except. Now, the answer is going to be D here. I will tell you why it is D, because here it says number 8 Foley's catheter, whereas the test is done with a number 16 Foley's catheter. So you have to fill the bulb of the number 16 Foley's catheter with 2 cc saline, and then it will be easily pulled out. That is what is the test of cervical incompetence. We all know about passage of number 8 Hagar's dilator without resistance. The key thing here is that this test is to be done in the premenstrual phase. Okay, it has to be done in the premenstrual phase. Then, as far as cervical length is concerned, yes, a cervical length less than 2.5 centimeters in the second trimester is the criteria. And if we talk about the internal os diameter, more than 2 centimeters in the second trimester could be used as a criteria, while more than 1.5 centimeters dilatation is the criteria in the first trimester, right? So that is the criteria in the first trimester. And when we talk about cervical incompetence, please remember there are a lot of times, so these are basically the tests, but a lot of times you can make a diagnosis only from the history as well, right? And the key words that you have to look for in the history are these. The patient is going to present to you with recurrent abortions, okay? That's the first key thing. Second, all these abortions are going to be second trimester abortions, right? So it does not cause first trimester abortions. Cervical incompetence will only cause second trimester abortions. The third keyword in the history is that it is a painful dilatation of the cervix, unlike labor, right? Which is also going to have dilatation and shortening, but that is painless. Sorry, I've just written the reverse. So in cervical incompetence, it is painless, while we said in labor, it is a painful dilatation and shortening. So in incompetent cervix, it is going to be a painless dilatation, right? And the fourth keyword in the history is going to be that with every pregnancy, right, with every pregnancy, the POG of the loss keeps decreasing. Right, so the POG of the loss keeps decreasing with advancing pregnancy, right? So if we see these 4 things in the history, then you make a diagnosis from the history itself, right? So the diagnosis of cervical incompetence may be from the history and it may be from the investigations, okay? Please remember, when you talk about passage of number 8 Hagar's dilator, or you talk about Foley's catheter, these 2 are tests which are done in the non-pregnant state. We don't do these tests in the pregnant state, right? So number 8 Hagar's dilator is a test we would do in the non-pregnant state to pick up cervical incompetence, right? And since I've told you that cervical incompetence is going to cause recurrent abortions, and recurrent abortions especially an MCQ, which is again very, very commonly asked in the All India exams, and they've been asking something or the other from it repeatedly. Please understand, when their question is about recurrent abortions, right, whether they're asking you about the cause in the first or they ask you in the second trimester, you're going to stick to this. The leading cause of recurrent abortions, whether the first or second trimester, remains as idiopathic. We are unable to find a cause. The second leading cause is APLA, all right? The second leading cause is APLA. The third in the list is uterine anomalies, right? Now, they could be congenital uterine anomalies or acquired, right? So, uterine anomalies is next in the list, followed by endocrinopathies, and then comes chromosomal. So, a lot of times you are doing this mistake. What? They're asking you recurrent abortion in the first trimester and you mark it as chromosomal. No, chromosomal is not the most common cause of recurrent abortions. Chromosomal is the most common cause of sporadic abortions. So please do not do this mistake. So whether they're asking you the first or the second trimester, you should really stick to this list or the order that I've given you, and you should answer it accordingly. Okay. Also, please remember the uterine anomaly which can cause recurrent first trimester abortions. Do not answer it as cervical incompetence. I just told you a little while ago, cervical incompetence classically causes only second trimester abortions, not first. So if we are asking you uterine anomaly causing recurrent first trimester abortions, we might as well answer it as septate rather than cervical incompetence, right? So just remember, cervical incompetence will only cause second trimester abortions, all right? I hope you're not going to make mistakes in this, because as I said, the All India people are very fond of asking this repeatedly in the exams. Let's go on to the next question. So it's a long one. I'm just going to pick up the keywords for you. So they say that the blood pressure is 150 by 110 persistently. She also has albuminuria, while there are no other symptoms. Very important. It says the blood pressure was normal in early pregnancy, right? And it started to rise at 30 weeks. Do you see that? So she had one record of a high blood pressure at 30 weeks. Before that, they're saying the records were normal, which means for sure this is not option D, right? Because when you say it is chronic hypertension, the blood pressure should be high in the first 20 weeks itself, right? Only then you can say it is chronic hypertension. Or maybe the patient was a known case of hypertension prior to her pregnancy, right? Or preconceptionally. Then we could have said that she has developed superimposed preeclampsia. But here, no. So this is not chronic hypertension at all. Then this is not gestational hypertension as well. Why? Because she has albuminuria. So gestational hypertension, the blood pressure should be high beyond 20 weeks, but there should be no proteinuria. So since in this question there is proteinuria, it cannot be gestational hypertension. Now we're left with whether she is severe or she is mild preeclampsia. So because the diastolic blood pressure is more than or equal to 110, and we are saying that it is persistently more than that, then yes, she is a case of severe preeclampsia, right? So please remember, when we talk about severe preeclampsia, this is what we need to know. In order to say that my patient has severe preeclampsia, either the blood pressure should be more than or equal to 160 by 110. Please understand, it doesn't have to be both systolic and diastolic. Even if one of them meets the criteria, it is going to be still labeled as severe. And that is why in our question, the patient is still going to be severe. All right? And or, right? There has to be evidence of end organ damage. Yes? And the end organ damage, we all know, we take it as, a platelet count which is less than 1 lakh. We take it as serum creatinine which is more than 1.1. We take it as liver enzymes more than twice the normal value. Yes. Then the fourth criteria is pulmonary edema, right? And the fifth criteria is cerebral or visual symptoms, right? Please understand that when you talk about this, I have already told you many times in the classes, but I'm just going to repeat it. Please remember, a proteinuria of more than 5 grams is no longer a criteria to say that it is severe preeclampsia. Similarly, IUGR is no longer a criteria to say it is severe preeclampsia, neither is oliguria a criteria. So these three things have been removed from the defining criteria of severe preeclampsia. For the defining criteria, it is these 5 that we have written. Okay. And also one of the newer things that I would definitely want to tell you is, we all know that when we talk about prevention of preeclampsia, we've told you about aspirin. And we've told you about low dose aspirin, which is about 80 milligrams, right? Now, one of the recent recommendations is that we should actually be giving a higher dose, and the newer recommendation is almost double, 160 milligrams of aspirin. I've given it as an update on the club as well. Maybe you can go and read it. But yes, this is the most recent recommendation as far as prevention of preeclampsia is concerned, right? And you might be asked this as well in the exams. So be careful about it. Right, let's go on to the next question now. Which of the following is not a sling operation for prolapse, right? And the answer is going to be A, Manchester repair, which is also called as Fothergill's repair. Yes, so Manchester or Fothergill's is not a sling operation, while Shirodkar's, Khanna's and abdominocervicopexy are all sling operations. So please remember, when you talk about Manchester repair, there are a couple of things that we would definitely want you to know. One is that in Manchester repair, please understand that it is a procedure where the uterus is preserved, right? So we would do it in women who are in the reproductive age group, right? And they don't want to undergo a hysterectomy, so they want to retain their menstrual functions, right? Second, we could do it in patients who have cervical elongation. Especially, you have to understand what type of cervical elongation, supravaginal elongation, right? Please also understand that Manchester Fothergill's repair should not be used in case the woman wants to conceive, right? So if she wants to preserve her fertility as well, then we should rather do the sling operations, right? So Fothergill's should be done for women who've completed family. That's important, right? So although she's in the reproductive age group, but she has completed the family, right? Also, I would want you to know the general steps of Fothergill. So I'm not going to give you too many details, but just the basic steps that you should know, right? Now, the first step is, a dilatation and curettage. So we call it as a preliminary dilatation and curettage. I will just tell you why we do it, right? So as I said, we do a preliminary D&C. That's the first step. The second step includes amputation of cervix. The third step is we're going to plicate the Macken-Rod ligaments. So we say plication of Macken-Rod ligaments in front of cervix. Okay. The fourth step is we perform an anterior colporrhaphy. And the fifth step is we're going to perform a colpo-perineorrhaphy. So repair of the perineum. So colpo-perineorrhaphy. Right, so these are the basic steps of a Manchester or a Fothergill's repair. They're important. I do presume that some of the exams might ask you this question this year, so you should know it. Now, some of you would be wondering, why are we doing a DNC here? Now, the reason we do a dilatation is that, first of all, the dilatation will help us, or it facilitates to help us pass sutures into the cervix, right? So it facilitates the suture passage into the cervical canal. Second, it prevents cervical stenosis. Okay, so it prevents cervical stenosis, and also because when you do dilatation, you're going to put a uterine sound. It gives you an idea about the elongation of cervix as well, right? So when you are going to sound the uterus, it is going to tell you about the elongation of cervix, right? So sounding is a part of dilatation. We say uterine sound is the first dilator. Okay, so before you put the Hagards, we have actually first put the uterine sound, and then we do the curettage simply to remove the dirty endometrium or to clear up the endometrium, right? And so the first step is actually a DNC, right? Now, please understand, out of the remaining three surgeries that we have talked about, right? Shirodkar's, Khanna and abdominocervicopexy, the best sling surgery is actually abdominocervicopexy, although it is difficult to perform, so not commonly done. While the most commonly done sling surgery is modified Shirodkar's abdominal sling, right? So modified Shirodkar's abdominal sling is the one we do most commonly, but the one with best outcome is abdominocervicopexy. Khanna's is no longer done. It is a historical importance, but yes, I would like you to know here that here the sling is attached to anterior superior iliac spine in Khanna's surgery, right? It is attached to anterior superior iliac spine, right? Okay, let's go on to next. So which of the following, so we have to answer which is not true. Okay, about physiological changes. Again, a topic which is repeatedly asked in, again, almost all exams, whether it is All India or it is Central Institutes, right? So we have to say which is not, right? And the answer is going to be D, TSH increases, right? Now, please remember that there is no increase in TH in pregnancy. In fact, in the first trimester, the TSH actually falls, right? In the first trimester, TSH actually falls, and after the first trimester, it starts rising a little, but it will only come back to pre-pregnant value. It doesn't increase, okay? So gradually over the course of rest of the pregnancy, it comes back to the pre-pregnant value, but does not increase. And in general, please remember, although we are writing that in the first trimester the TSH decreases, it does not go out of the normal range. It still remains in the normal range, right? So in general, we say pregnancy is actually a euthyroid state, right? Diaphragmatic excursions, yes, increase. Do not confuse it with the fact that the diaphragm rises. Yes, the diaphragm rises in pregnancy, there is no doubt, and it rises by 4 centimeters, but the movement of the diaphragm, which is up and down and which are excursions, they actually increase. We all know pregnancy is a state of hyperinsulinemia, and this is because of the insulin resistance, right? And this is because of the hormone HPL, right? Also called as HCS, human chorionic somatomammotrophone, right? And please remember, the same question may come on the other way around as well. So we might ask you, what is the main function of HPL? So we are going to answer it as endocrinal, okay? The main function is endocrinal and not fetal growth. Please remember, for fetal growth, you're going to answer it as insulin-like growth factors or insulin, not HPL. And yes, there is compression of IVC by the big gravity uterus, especially in the later half of the pregnancy. And this is what is called as the supine hypotension syndrome, right? So these are all physiological changes. And as I said, they're repeatedly asked in the exams. Also, I would like to add here that when you talk about insulin resistance, please understand that as POG increases, the insulin resistance also increases, which means in pregnancy, there is going to be hyperinsulinemia, and the levels will keep increasing as pregnancy advances because the resistance is also rising, right? So there is hyperinsulinemia and the levels keep increasing, right? Let's look at question number 7. All are true about estrogens, and the key word here is except, right? And the answer is option number B. Now, it might be something new for you people, but to put it more simply for you, that yes, the estrogen receptor are of 2 types. There are alpha receptors and there are beta receptors. So usually when you talk about the reproductive organs, whether it is the uterus or it is the ovary or it is the breast, they all have alpha receptors, okay? So they have the alpha receptors. The beta receptors are present elsewhere, for example, bone, heart, right? Even in the kidneys, right? There we have the beta receptors. Brain, right? They have the beta receptors. The only exception to the rule I've said is ovary is a little complex. So what happens is that the ovarian stroma cells have alpha receptors, while the ovarian granulosa cells have beta receptors, right? So ovarian, the granulosa cells have beta receptors, but else otherwise you can remember it as alpha receptor, all right? Yes, ferning is brought about by estrogen, and apart from estrogen, for ferning there is a requirement of high amount of NaCl, right? And when you talk about ferning, please remember that you can appreciate or identify or see ferning as early as 8th day of the menstrual cycle and as late as day 18 of the menstrual cycle, right? And when you talk about estrogen receptors, please understand that the estrogen receptors are intranuclear receptors, right? They're intranuclear receptors. Option C is absolutely correct. Estrogen is what is required for initiation of LH surge, right? And we need high levels of estrogen. The minimum requirement is 200 picograms for a span of 48 hours. That's the minimum requirement to bring about the LH surge. Although for initiation, we only need estrogen, but in case the question is not about initiation of LH surge, but rather about maintenance of the surge, then for maintenance, both are required, E and P, right? So for maintenance of the surge, both E and P are required, but for initiation, it's only estrogen. Yes, E1 or estrone is what increases in PCOS, right? Please remember, in PCOS, the E2 levels usually remain normal, right? So the E2 levels usually remain. So total E2 in PCOS is normal, while it is the E1 which is raised. And that's why we say that in PCOS, the ratio of E2 to E1 is reversed, right? It is reversed. And as far as E1, E2 and E3 are concerned, you should definitely know the potency status of these. So the strongest of the three is E2 or estradiol, then comes E1 and then comes E3. So that's the potency order of these estrogens. So which means the strongest naturally occurring estrogen is estradiol. That's the strongest naturally occurring estrogen, right? Fine. Let's go on to the next question now. Right, so what syringe is this? I think we showed you it in the DVT itself and you shouldn't have done it wrong. So this is a MVA syringe, right? It is a MVA syringe and this syringe has a capacity of 60 ml, right? And here it is, these are the valves. So it could be bivalve or it may be a single valve, right? So you may even see a syringe with two valves. Right, and what you have to remember is that MBA is a method of MTP up to 12 weeks. So remember that MBA is actually an alternative to suction and evacuation. So suction and evacuation can be done till 12 weeks and even MVA can be done up till 12 weeks, right? As far as medical outpatient abortion is concerned, although we have told you many times, I'm just repeating it. The medical outpatient abortion, please, it is a law in India, and as per the MTP Act and the MTP law, this outpatient abortion with MIFI and MISO, right, can only be done up till 7 weeks. Do not answer it as 9 weeks. Please understand, it is the 9 weeks is the WHO recommendation. So until unless they don't ask you about WHO, you have to answer here what the Indian law says. Very few places we have our own law, and wherever we have it, we have to follow the law of the land, right? So for us, it is going to be 7 weeks. Okay. Okay. So what is the contraception of choice in a woman with menorrhagia and hypertension? Right. So once you say that, it means we want to avoid the E. Right. We want to avoid the E and especially the combined agents which have both E and P. Right. So which means we would avoid OCPs, transdermal patches as well as vaginal rings. So a transdermal patch as well as a vaginal ring, they're both E plus P devices as well, and they have the same contraindications as oral contraceptive pills. So this patient is an ideal candidate for Mirena. One, Mirena has no effect on the blood pressure, right? And two, menorrhagia. So Mirena, what does it do? It brings about endometrial atrophy, right? And it will actually reduce the menstrual blood loss, right? So it is going to be helpful in menorrhagia as well. And please remember that Mirena over a span of time actually can produce amenorrhea as well, right? So it usually takes around 6 months, and after insertion, it will produce amenorrhea. And in fact, this is something that you should all remember, that when a lot of times these exams ask you the non-contraceptive benefits of Mirena, right? So when they ask about non-contraceptive benefits of Mirena, they're all to do with conditions which have excessive bleeding, right? Because it brings about endometrial atrophy. So it may be DUB, it may be menorrhagia, right? And please remember, since we are talking about non-contraceptive benefits, as I said, they're usually to do with the bleeding ones. Remember PMS, premenstrual syndrome. Here, Mirena has no action, okay? So no role. So we don't use Mirena for premenstrual syndrome. Although yes, OCPs have been tried and they have been shown to have some role, but not Mirena, right? So Mirena has no role as far as PMS is concerned, okay? And when we talk about oral contraceptive pills, I've been repeatedly saying that most of the exams want to ask you about absolute contraindications, and you should remember the absolute contraindications. And hypertension is one of the absolute contraindications, right? So especially if the blood pressures are more than 150 by 100 millimeters of mercury, we would never give oral contraceptive pills, right? And we would talk about the other contraindications as well. I think we do have another question where this becomes more relevant. So we'll talk about the other absolute contraindications in a little while. Right, question number 10 says, Wertheim hysterectomy is done for which of the following stages of cancer cervix? Right, so the answer here will actually be C, both A and B. Stage 1A, 2, I think you all know that we do Wertheim's hysterectomy. 1B1, how come 1B1? Now here, if you remember what is stage 1B1, tumors less than or equal to 4 centimeter constitute stage 1B1. And if we do not mention anything, then normally we say for stage 1B1, the surgery has to be a Meigs hysterectomy, which is also called as a radical hysterectomy and also called as a type 3 hysterectomy. Right? But if we specify, which is 1B1, and if the tumor is less than or equal to 2 centimeters, we would actually do a Wertheim's. And that is why here the answer is C. You should all know that Wertheim's is the one which is called as type 2 and also called as modified radical. Please remember, as if the tumor is more than or equal to 4 centimeters, which is stage 1B2, our treatment of choice becomes chemoradiation, right? So the treatment of choice becomes chemoradiation in these cases. What do we do for stage 1A1? So 1A1 is important again. Remember, the general answer for stage 1A1 is going to be simple hysterectomy, also called as type 1 hysterectomy. Right? And the complete name is simple extrafascial. But if we talk about stage 1A1 and the family is not complete, right? So if it is 1A1 with family not complete, then what do? Then we do conization, right? So which is a therapeutic conization, right? So for 1A1, general answer I'm saying is simple hysterectomy or type 1 hysterectomy. And we do conization in case we mention that the family is not complete, right? So let's go on to the next question now. Okay, all the following are first trimester findings of Downs except, right? And the answer is going to be decreased AFP. Decreased AFP, please understand, is a finding of second trimester, right? That's a test we do in the second trimester, not in the first trimester. Increased HCG and decreased PAPA are, yes, findings of first trimester, and they are together called as the dual test. Yes, they're together called as the dual test, which is done between 11 to 13 weeks, right? And increase HCG and decrease PAPA which will be what is called as a positive screening test, right? Increased nuchal translucency, yes, is again done in the first trimester, the ideal time being 11 weeks to 13 plus 6 weeks, which means 13 weeks and 6 days. And the dual test and NT together are called as the combined test, right? So if you give the risk assessment with all these things, so dual test plus increased NT, then it is called as a combined test, right? Please understand that nuchal translucency could be normal as well. So you should know what is abnormal in this time. Values which are more than or equal to 3 mm are considered as a positive screening test. Do not get confused, because I presume that these are the questions which are very, very simple, and we should not make mistakes in these simple questions in the exams. You should know the test of the second trimester as well. So the triple and the quadruple, right? And I'm sure by this time you know them by heart. So triple has alpha fetoprotein. The only mistake you might make is UE3. So remember, it is unconjugated estriol and not estradiol, right? That's again something that PGI people are also very fond of asking. And the third component of the triple test is HCG, right? And the HCG would be high, the alpha fetoprotein would be less, and UE3 would also be less, right? As far as the quadruple test goes, these three remain the same, and we add a fourth one, which is going to be inhibin A. And the inhibin A is going to be more than expected. So that's what is a positive screening test of the second trimester. And whether we talk about triple or quadruple test, both these tests can be done anytime between 15 to 20 weeks, right? So which of the following is the most common site of endometriosis? Now the general answer for the most common site of endometriosis is ovary, which is not in the options. So here the answer is going to be the pouch of Douglas, right? And after pouch of Douglas, this is the order you have to follow. It is going to be the posterior leaf of broad ligament. Then comes the uterosacral ligaments. Then comes the fallopian tubes, sigmoid colon, and appendix. So that's the order or decreasing order of how frequently you would find endometriosis in these sites, right? So that's the order you should follow, and it is important. Most of the exams are going to ask you something or the other about it. So a lot of times, so you know, AIPG might ask you about the sites, while PGI might ask you about the theories. In general, please remember that the most commonly accepted theory of endometriosis is the Sampson's theory, right? Or the theory of retrograde menstruation. Yes? If that is not in the options, the second most accepted theory is the theory of coelomic metaplasia. So everywhere where they ask you how do you explain endometriosis at this site or that site, the order remains the same. So the best answer is Sampson's, while the second best answer is coelomic metaplasia. The only place where you change answer is umbilical endometriosis, right? So do not answer it as you know, Sampson's or coelomic metaplasia for umbilical endometriosis. For this, you should either answer it as lymphatic spread or a hematogenous spread, right? So either hematogenous or lymphatic, but not Sampson's or coelomic. Okay. And we might try and ask you clinical questions on endometriosis as well. Please remember, you know, if we write a combination of any of these, which is pain, and especially it is going to be dysmenorrhea, we might use the word progressive dysmenorrhea, okay, which means it keeps worsening, right? The second keyword is an adnexal mass, and the third is infertility. If you see these in combination, maybe all three or two of these, you should start thinking about endometriosis. So pain, adnexal mass, and infertility together lead you to the diagnosis of endometriosis. And you know, you would typically see endometriosis in the age of 25 to 35 years of age. You don't see it really in the older women, right? So you know, don't make a diagnosis of endometriosis at the age of 45 or 50 years or 40 years for that matter, right? So this is something, so age also becomes an important part when you're taking differential diagnosis or the most probable diagnosis, right? Fine. Right, so name the instrument which is shown below. I think this was an easy question as well, right? So this is an artery forceps, right? It's an artery forceps. And the only confusion you could have is between the artery and a needle holder, right? Now, these are the things that you should look at. If you look at a needle holder, you know, the blades are not going to be this long. In needle holder, the blades are short or small, right? So these are long blades. You don't see these kind of blades in a needle holder. They're small blades. Not only that, the most important thing is when we open a needle holder, you're going to see a groove in it, right? Whereas if you see, we have shown you the open instrument here and there is no groove in a artery forceps, right? So this is, the groove is the most important part of identifying a needle holder. And also a needle holder will always have a box type of a joint. The joint of a needle holder is called as a box type joint. Whereas an artery forceps, it could, usually it's a screw type joint, but it could also be box, but also is the word. in needle holder, it's only the box type, right? And the needle holder, as you can see, the artery forceps is showing you transverse serrations. So the needle holder may also have crisscross serrations, but yes, you could see the transverse serrations in the needle holder as well. What do we use the coccus for? And it will have a tooth. A coccus has a tooth. So if you open it, you will see a teeth in it. And the coccus is used for doing ARM, artificial rupture of membranes. And what is Green Armitage? Green Armitage is nothing but a hemostatic clamp, right? So we use it to maintain hemostasis, right? Okay. The following ultrasound image of the ovary, so the image is not here in the this thing, but I'm sure you remember the image from the test paper. Anyways, the ultrasound image of the ovary that we gave you is a dermoid, and it had a very, very characteristic thing, which was what? We had given you an arrow pointing towards the Rokitansky protuberance. Right, so it's the Rokitansky protuberance, which was the key thing. So you see a black cyst, and then you see the Rokitansky protuberance. This was the exact image, and we had given you an arrow in it, right? So this was a dermoid cyst. Remember, dermoid is a cyst, so most of it appears black. Only this area, which is the Rokitansky protuberance, appears white, right? And so you should remember the complete name of dermoid, which is a mature cystic teratoma, right? It's a mature cystic teratoma, right? And the Rokitansky protuberance is important. Now, please understand that dermoid are usually benign. They have a low risk of malignancy. The risk of malignancy ranges between 0.2 to 2%. Now, if at all the dermoid develops a malignancy, it usually happens in this Rokitansky protuberance. So that's the importance of the Rokitansky protuberance as well, right? This is the site where it might show the malignant change. And, the most common malignancy to occur in a dermoid is actually a squamous cell cancer, right? It's a squamous cell cancer, right? And not only this, dermoid is the most common ovarian tumor to undergo torsion. So we might ask this question as well to you quite frequently in the exam. So it is the most common ovarian tumor to undergo torsion. Remember, dermoid is the most common ovarian tumor in reproductive age group, as well as the most common ovarian tumor in pregnancy. Those are the other important words that we try and ask you. Please also remember that dermoid really doesn't show you it is inert, so it doesn't release any tumor markers. It's inert per se, but very, very rarely a dermoid may produce HCG. Okay. Right. So which of the following is not true about HELLP syndrome? That's an interesting question, and I want to know how many of you got it right. The answer is D. The problem here is the word conjugated. So you know what? In HELLP syndrome, there is hemolysis, right? There is hemolysis. And when there is hemolysis, it is indirect bilirubin or the unconjugated bilirubin that rises, not the direct or the conjugated one, right? So that's the problem here. It should have been unconjugated or indirect bilirubin, right? And yes, although HELLP syndrome usually is a feature of severe preeclampsia. So HELLP, yes, is severe preeclampsia, but in about 10 to 15% of patients, the blood pressure may be normal, right? So that's interesting, and that is why blood pressure is not at all a criteria to make a diagnosis of HELLP, right? Blood pressure is not a criteria to make a diagnosis of HELLP syndrome. Okay? Then we all know that preeclampsia is more commonly seen in nulliparous, and why? It is because of an altered immune response. So you know what, preeclamptic women, one of the theories is that they show an altered immune response to the paternally derived antigens, right? So they show an abnormal immune response to paternally derived antigens, okay? And that is why it is generally seen more commonly to be happening in nulliparous women. But interestingly, HELLP syndrome on the other hand is more commonly in multiparous. So multiparous is actually a risk factor for HELLP and not nulliparous, okay? And yes, although there is hemolysis, LDH is generally not a part of the diagnostic criteria, right? The diagnostic criteria for HELLP come from the term HELLP itself, right? So H is hemolysis. So we look for peripheral smear and schistocytes in them, right? And then the serum bilirubin will be raised. It is going to be more than or equal to 1.2. EL is elevated liver enzymes, so AST more than or equal to 70 international units, and low platelet count, so a platelet count of less than 1 lakh, right? So that's those are the only 4 things which are required to make a diagnosis of HELLP. No blood pressure is required to make the diagnosis. Please remember, the most common symptom is pain, and it has to be an epigastric or a right upper quadrant pain. It cannot be just any other pain, right? So right upper quadrant or epigastric pain is what is the characteristic or the most common or the first symptom of HELLP, right? Then you must also know that when you talk about HELLP syndrome, very often these exams have been asking you the recurrence risk. So the recurrence risk is in the range of 4 to 7% for HELLP syndrome, right? So it's in the range of 4 to 7%. Let's go on to the next question. So all are soft markers for aneuploidy except, right? So the answer is nuchal translucency. So please remember, soft markers are second trimester ultrasound findings, and the one we take to be the soft marker is not nuchal translucency, it is actually nuchal fold thickness. So very important, and do not get confused between the two. Nuchal fold thickness is something that you see in the second trimester, and more than or equal to 6 mm is a positive screening or a positive test, right? The other important soft markers are, yes, echogenic bowel foci as well as echogenic intracardiac foci. Very, very important, hypoplastic or maybe even a absent nasal bone. They have a single palmar crease, which is called as the simian crease. Also, sandal gap is taken to be a soft marker. The other soft markers are a short humerus and a short femur. These are again important, so you should know them. And mild pilectasis or dilatation of the renal pelvis or hydronephrosis is also an important soft marker. So mild pilectasis, or they may use the word mild hydronephrosis. Pilectasis is dilatation of the renal pelvis, right? So these are important soft markers, and as I said, they are ultrasound findings of the second trimester, and they're called as soft because by themselves they do not tell us that the baby is aneuploid, but the presence of more than or equal to 2 soft markers definitely increases the risk of aneuploidy in the baby or in the fetus, right? Okay, the next question says all are true about puberty except, right? So the answer here is D. I think this is an easy question as well. Pubarchy and adrenarchy. Okay, although they are secondary sexual characters, they are not brought about by estrogen. These are brought about by testosterone or androgens, right? The rest of the statements are true and they're important. So yes, central precocious puberty will have high levels of LH and FSH, and in fact this is one of the tests to differentiate central precocious puberty from peripheral. In peripheral, the LH and FSH levels are going to be low, whereas in central they are going to be high. The first sign in boys is testicular enlargement followed by penile enlargement, right? And the first visible signs, the word here was visible, is definitely thelarchy, whereas if the first sign was written and the word visible was not there, then we would say that the first sign is in girls is growth spurt, right? And since here we're also talking about precocious puberty, please remember the age criteria is if the girls develop secondary sexual characters before 8 years, so 8 years is the cutoff for girls for precocious puberty, and if the boys develop secondary sexual characters before 9 years, so 9 years is the cutoff for boys. You should also know the cutoff for delayed puberty, right? For girls it is 13 years and for boys it is the age of 14 years. So you should definitely know these cutoffs. And once you talk about precocious puberty, we want you to know the causes as well. So please remember, the most common cause of precocious puberty is idiopathic, right? While the most common cause of delayed puberty is a constitutional delay, right? So constitutional delay for delayed puberty and idiopathic for precocious puberty. Okay, a woman taking OCP is at an increased risk of stroke. Which of the following? Now, although all of these are risk factors for stroke, but the highest association or the highest incidence of stroke or risk of stroke is if you give oral contraceptive pills to hypertensive patients, right? So the single best answer here is going to be hypertension, right? And that's what we said. We would never, in the previous question as well, so hypertensive patients, we are not going to prescribe combined oral contraceptive pills. Let's see this. So this was the question that I was talking about, that we're going to talk about the absolute contraindications, because the All India exams are asking it. They may make a clinical question out of it and ask you, but yes, they are asking you, or they may ask you as a direct MCQ as well, which is what is done more frequently. Any patient who has a known case of venous thromboembolism, a known case of stroke, and a known case of coronary artery disease, a known case of breast cancer. Now, here I want to clarify something else as well. Please understand, this is a known case. A lot of times you've been asking this question on the club, is OCP a risk factor for breast cancer? The answer is no. No, no, and no. Oral contraceptive pills, the ones that we're using in modern obstetrics or in modern gynecology, are only low dose pills. And low dose pills definitely do not increase the risk of breast cancer. That was an association seen with high dose pills, which are no longer used. All right. Then the other important are, as I said, hypertension, especially if the blood pressure is more than 150 by 100, we are not going to prescribe OCPs. Then diabetes, only if it is associated with vasculopathy. Migraine, only if it is associated with aura or focal neurological deficits, right? Smoking, only if the woman is more than 35 years and she smokes. So more than 35 years plus a smoker becomes an absolute contraindication. Then if my patient has a suspected pregnancy, right, or she has deranged liver enzymes, they become, again, absolute contraindications. Also remember, first 6 weeks postpartum, we are not going to prescribe combined oral contraceptive pills, because again, the risk of venous thromboembolism is very high in the first 6 weeks postpartum, right? Okay. Important parameters for semen analysis are all except. So here we are going to go with semen fructose, right? So the answer is going to be semen fructose. I hope that you've all read except in the question. Now, amongst the parameters, the single most important is motility, and the second most important is sperm concentration. Okay, so single most is motility. The second most important is sperm concentration. Also, the volume is important. In case we go more specific, for IVF, the most important parameter of the sperm is motility, whereas for ICSI, intracytoplasmic sperm injection, the most important sperm parameter becomes the morphology. You should all know the WHO parameters for semen analysis. All exams are asking this, including AIMS as well as All India exams, right? So volume should be more than 1.5, pH should be more than 7.2, total sperm count more than 39 million per ejaculate. Okay, while sperm concentration should be more than 15 million per ml. Total motility should be more than 40%, while progressive or a forward motility should be more than 32%. Okay, then morphology should be more than 4%. Morphology more than 4%, and vitality should be more than 58%. How many sperms are alive? And the leukocyte count should be less than 1 million per ml. Okay, that's about the leukocyte count. Please understand, if one of these semen analysis comes out to be defective, before you start treating the patient, you have to confirm the abnormality in a second semen sample, right? So the most important thing is confirm the abnormality in a second semen sample, right? Okay. Which of the following is true statement regarding partial mole? The answer is D. Placenta can show enlarged cystic spaces on ultrasound. So yes, this is what is called as focal hydropic change, and it is one of the things that we should look for if we want to pick up partial mole or ultrasound. Otherwise, ultrasound is not ultrasound can give you misdiagnosis, right? A lot of times in partial moles, the report will come as missed abortions. So if you really want to not miss out the diagnosis, you should look for these focal hydropic changes in the placenta. Also, the other ultrasound feature of partial mole is that the sac that you see in partial mole is going to be an abnormal looking sac, by which I mean the transverse diameter of the sac or gestational sac will be bigger than the AP diameter. Usually they're equal. The sac is usually a symmetrical sac, but here it is going to be an asymmetrical sac. What's wrong with option C? Preeclampsia and early onset preeclampsia is never seen with partial moles. It is a feature of complete moles. And the cause is again more number of paternal antigens, right? No, partial moles are not monospermic. They are usually dispermic. What is the most common karyotype? It is 69XXY, right? So they are triploid 90% of times, they are triploid, and 10% of times they are tetraploid, right? Fertilization of an empty ovum by 2 sperms. 2 sperms is right, but empty ovum is wrong. The ovum here is not empty, it is a normal ovum. Empty ovum fertilized by a single sperm is a feature of complete mole, right? So empty ovum fertilized by a single sperm is complete mole, and that is why we say that the complete moles are monospermic while partial moles are dispermic. The most common karyotype for complete moles is 46XX, again seen in 90%, while the remaining 10% are 46XY, right? So those are important things that you should know when we talk about the genetic makeup and ultrasound findings. Again, on ultrasound as well, please remember the theca lutein cysts that you see are only and only seen with complete moles. They are not ultrasound features of partial moles. And fetal tissue, very important. Something basic, and I'm sure you all would be knowing it by now. Fetal tissue is seen only in partial moles. There is no fetus in a complete mole. Okay, a 26-year-old lady is being evaluated for an infertility and she shows a bilateral cornual block on HSG, right? So what is the most appropriate management? And the answer, again, we've discussed it many times, is laparohysteroscopy. Please remember, majority of times the bilateral blocks on HSG are physiological, right? They are because of the cornual spasm. And doing a simple procedure like hysteroscopic cannulation is good enough for them. So the treatment actually is hysteroscopic cannulation, and we combine it with diagnostic lap, which is the confirmatory test, right? So the procedure we do is a single procedure which is both confirmatory and therapeutic. So we do a diagnostic laparoscopy plus hysteroscopic cannulation. The other indirect thing that you should know is, since we are writing that majority of times it turns out to be physiological, in case they ask you what kind of block on HSG will have good prognosis. Okay, is it a proximal block, is it a distal block, or is it a mid-segmental block? So the best prognosis is actually seen with cornual blocks, again for the same reason, because it turns out to be physiological a lot of times, right? Now, what do you do if it is not a physiological block, or you cannot open the block by hysteroscopic cannulation? Now, in case the hysteroscopic cannulation fails, then yes, we take these patients up for IVF. By which I want to tell you that it does not mean that IVF is the best treatment for cornual blocks. We just want to say that IVF is the last resort for treating cornual blocks, right? So whether they ask you the most appropriate, whether they ask you best, or whether they ask you the next step, please go with hysteroscopic cannulation or laparohysteroscopy, right? So you go with hysteroscopic cannulation or laparohysteroscopy, right? Okay, let's go on to the next question. Primea gravida presents at 8 weeks, okay, with pain and spotting, and on examination the os is closed. So I'm underlining the keywords for you. The ultrasound shows an intrauterine sac with cardiac activity. So what do you think is the diagnosis? So this is a clear-cut case of a threatened abortion, right? And since it is threatened abortion, the management for this patient is bed rest. So whatever we do for threatened abortion is actually empirical. For example, bed rest, progesterone supplementation, right? So they are all empirical treatments. We have no specific treatment for threatened abortion, right? In case the cardiac activity was absent, then what would be the diagnosis? Missed abortion. And then we will have to induce an abortion for this patient, right? And then the answer could be A, give misoprostol. So if it is a missed abortion, our management is going to be induce the abortion, right? In case the os was open, right? In this case, we've written os is closed. But if the os was open, then what is the diagnosis? Inevitable abortion, right? Then the diagnosis would have been inevitable. And in inevitable, you really don't have to do anything. The process would be completed by itself, but you could still give misoprostol to hasten the process of expulsion, right? To speed it up. But even if you don't give it up, it is bound to happen naturally as well, right? Okay. A patient presents with post-hysterectomy vault prolapse. What level of support loss is this? So, prolapse of the vault is again a level 1 problem, right? So when you say level 1, they are made by the uterosacral and the cardinal ligaments, and a defect in these leads to apical defects, okay? And what all comes in apical defects? It is going to be uterocervical prolapse, so that is also level 1. Enterocele is also level 1, and vault prolapse is also level 1. Okay. The best surgery that we can do for vault prolapse is abdomino-sacro-colpopexy. That's the best one. The one that we can use for prevention is uterosacral suspension. So uterosacral suspension is done for both prevention as well as treatment. So particularly if we ask you about prevention, it is uterosacral suspension. Also remember, although we do McCall's culdoplasty for enterocele, so if we ask you what is it a surgery for, it is a surgery for enterocele, but McCall's also prevents vault prolapse later in life. Okay, so both uterosacral suspension and McCall's could be used for prevention of vault prolapse later in life. But if you have to go with one, I would say go with uterosacral, because McCall's we generally say say it is a surgery for enterocele, right? And remember again, McCall's is not only the treatment for enterocele, it is also the prevention for enterocele, right? So whenever you're doing a vaginal hysterectomy for prolapse, whether or not enterocele is present, you should do a McCall's. Why? Because it will also prevent enterocele from developing later in life. So all the following are pathological in pregnancy, except, we just discussed this, so increased diaphragmatic excursions. This is physiological. Please remember, in pregnancy, respiratory rate shows no change. Okay. Now, exertional dyspnea. Okay, exertional dyspnea is definitely physiologic. But once we say progressive dyspnea, it is no longer physiologic, it becomes pathologic. Cardiomegaly is never physiological, it is pathological. Please understand that only the cardiac silhouette on the X-ray may appear a little bigger or larger in size, but actually there is no cardiomegaly. So cardiomegaly is pathological. Again, please remember, there is no change in the central venous pressure in pregnancy. So if you are seeing persistently distended neck veins, right, it is pathological, right? So persistently distended neck veins is going to be pathologic. I'm sure you all know about diastolic murmur. We've been asking that off and on in the exams. So please label it as pathological, right? So diastolic murmur, pathological, indicates an underlying heart disease, right? All right. All are components of AMTSL except the answer is D. The component which is in AMTSL is intermittent uterine tone assessment. Right? So it is intermittent uterine tone assessment and not uterine massage. Uterine massage is something we do for treatment of PPH. Okay? Not as prophylaxis of PPH. Controlled contraction is what is called as modified Brand Andrews method, right? Please remember, delayed cord clamping is a universal recommendation. Now, if you have the same question, so all our components of AMTSL except in one option is early clamping and one is uterine massage. Both are wrong, but the answer that you're going to pick up for except is going to be early cord clamping. That is going to be a better answer. So early is definitely wrong. We are not doing early cord clamping. As I said, the routine is delayed clamping. Early is going to be reserved for neonatal resuscitation or babies who need resuscitation and in Rh negative pregnancy, right? Else we are doing delayed cord clamping. Oxytocin, please remember, remains the drug of choice for prophylaxis as well as treatment of PPH. The dose here is 10 international units, preferably given as IM bolus. We could also give it as an IV infusion, but not IV bolus, right? So IV is going to be infusion. Please remember that misoprostol can be used for AMTSL, but it is not the drug of choice. Remember, misoprostol for prophylaxis or treatment is to be used only when we cannot use IM and IV drugs, right? So if we cannot use IM and IV drugs, only then we resort to misoprostol. The dose of misoprostol for prophylaxis of PPH or in AMTSL, right? So for prophylaxis, if you have to answer misoprostol, it is 600 micrograms and it is per oral, okay, as far as the WHO recommendation goes. For treatment of PPH, it is 800 micrograms and it is sublingual as far as the WHO recommendation goes. So those are some of the important things that you should know about AMTSL and things that you should know from this CBT. I hope you do really well in your main exams, and I hope you come back with the feedback that you knew everything in obs and gynae, right? So all the best from my side. Study hard and keep pushing. God bless.